Hi, good afternoon, everyone. Thank you for joining us. We're going to start with one of the longer cases, which we're doing in the DDU. It'll be the first year that we'll be doing this in the written. So the final question, instead of being a written question, a short answer question rather, you'll be asked, you'll have about hopefully 20, 25 minutes to look through a more full study. And I'll give you an example now, which Joe will do, and then just give us the conclusion at the end. You don't have to write anything, any of the findings or anything, just give us the conclusion at the end. So I'll try and share my screen and share that. Beautiful. All right, Joe, you're in charge. Tell me to go backwards or forwards with the study and then go through your conclusion at the end, okay?
I'm just reading the stem.
Take your time.
Okay, scroll forward. I've just got your haven't got your loops. It's just the first slide. It's not as presented.
Why the hell is that then? Screen sharing is paused. Resume share. Sorry, let me, why are you doing that? I might just try something different. Excuse me. Sorry. See technical areas. How about that?
That's better.
Cool. Whenever you want to go forward, just let me know.
Okay. Go forward. Equality.
Maybe while we're doing this, I want everyone else to have a look at it and imagine what you'd have as the pass fail, right? So there are some things that we got to pick up, some things you're allowed to miss. So you've got sort of like terminal failures, if you like, and then there's just mild things that we're going to do, and then we're all going to hammer Joe at the end of it.
Go forward. Go forward. Go forward. Go forward. Can I ask a quick question?
Yeah.
I can't quite see the where the gate is on those two.
Yeah, no problem. So the top one is your lateral mitral annulus, and we'd probably give you the values there. So it'd be like the E prime is like 5 centimeters per second. And then the bottom one is the medial annulus, and that's also about 5 centimeters per second. Then on the top right, you've got your pulse wave Doppler, obviously on the mitral valve inflow, LV inflow view. So the tips of the mitral valve leaflets. And you've got an E wave, which is probably 1 meter per second, and an A wave, which would be 0.3 meters a second. So an E to A ratio of like 2.5, 3.
Okay, go forward. Go forward. Go forward. Go forward. Go forward. Go forward. Go forward.
I think that's it.
Okay. So I'd have a bit more time to go through those pictures on the actual written.
You got it. So you'll be in
Okay.
charge of the screen, and
Yeah.
you'd be able to have maybe, you know, I'm hoping 25 minutes. So it's going to be, I'm asking them to get rid of normally it's 15 minutes per question. I'm asking them to get rid of the 10 minutes reading time at the beginning, because I said it was, you know, it's not that useful. And then you got 25 minutes for this, and you'd have a few more slides. So you'd normally have 20 slides. And I think we probably had about 10 or 15 there.
Okay.
Beauty.
Alrighty. So the LV is normal size with increased wall thickness. There is global LV systolic dysfunction with some regional wall motion abnormality in the anterolateral and lateral walls. There is diastolic dysfunction, severe diastolic dysfunction. The RV is normal size and function, but there are signs of raised pulmonary pressures with a dilated and fixed IVC and hepatic flow reversal. The most striking valvular problem here is the mitral valve, which in this New Zealander young gentleman who's had a history of 3 months shortness of breath, which is acutely worsening, may indicate mitral stenosis from rheumatic fever. He has thickened anterior mitral valve and posterior mitral valve leaflet. The posterior mitral valve leaflet is more restricted than the anterior mitral valve. There is flow acceleration through the mitral valve, and this would indicate, along with the E velocity, and along with the E velocity would indicate severe mitral stenosis. There's definitely chronicity based on the ongoing effects due to the LA, dilated LA, pulmonary APO and RV, and right-hearted pressures raised. The aortic valve is thin with central coaptation and doesn't show any signs of aortic stenosis. The tricuspid valve and pulmonary valve weren't shown here. So in conclusion, this is a LV. This is probably severe mitral stenosis with that could be rheumatic disease with chronic LV systolic and diastolic dysfunction with raised pulmonary pressures.
With an apical thrombus there, possibly apical thrombus.
Oh yeah, I did see that as well. I wrote that down on my list. From the contrast, there was a small apical thrombus.
Just like a dilated idiopathic cardiomyopathy with
Nice. All right, let's go back over it.
In here, pretty
Nice.
cool.
Does anyone have anything else that they would like to add to that?
So there's a lot to go through in a short time.
Yeah, and this is what it's all about.
I think I'd be able to write much more in the actual paper.
I'm not asking you to write. I'm going to show you what I think is a perfect answer at the end of this, okay? Because I'm not asking you to write a lot. I'm asking you to, just like you do in a conclusion, is you've got to put through all the important information in a discernible way that is easy to interpret.
Yeah.
I'd have thought there's not a lot of things in there. Does anyone want to add anything else that they've seen that was not mentioned?
Was the LV internal diameter more than 6?
Very
Oh,
nice.
I thought it said 5. I thought it said 5.
Sorry.
So it might have been me
No,
reading.
the internal diameter is 6.3.
Yeah, okay. I think I need to put my glasses on.
No problem. No problem. Excellent. We'll take that one off then. I can take that
Yeah.
size out. Anything else?
Sam, can we look at the inflows again? Mitral inflows. It just the E and the A, it just kind of looked like a weird spot based on the ECG.
Yeah,
Like
a very common
right
thing I think you'd find is that they don't often match up and they don't sync. So it's not an uncommon finding. So the actual reference standard is the Doppler. And so if you do it based on it, they're often a little bit out. So yeah, I don't read too much into that. It's a pain in the ass, isn't it? Anything else?
I needed to.
All right.
I also needed to mention like the LA pressures are, the LA is dilated and the LA pressures are high as well.
Very nice. So, okay, let's go through a couple of things. So rheumatic fever, if you're going to call a mitral valve rheumatic fever, so I think these valves are thickened. I do not think they're stenotic. Okay. We don't see that hockey shape appearance. And so this would be, I think this would make me nervous to pass you for this case. And again, I hope I'm not being too rude, but I think we just got to be honest with each other. So be aware of overcalling things. So absolutely, they look thickened, but there's no hockey shape appearance to it. And I didn't give you any gradients at all across the mitral valve. And if I'm not giving you stuff like that, it's not stenotic. I'm not trying to trick you. No one is going to try and trick you. So if you're not seeing, in particular, I think with valves, I'd often give you more than one picture. You'd see different things. It would just be like a standard full study where you'd be seeing valvular analysis from multiple different angles. So there'll be clues in there. If this was stenotic, I'd have given you something more in there. Having said that, you know, because I don't think that even with mitral stenosis, I don't think we routinely measure the mean pressure gradient, for example, you normally just have the E to the A. So if you're not seeing it, don't go hunting. I agree it is thickened, but why is the valve not opening well? Or why do you think that you've got, you said you thought that you had, yeah, nice. We got LV dysfunction. I think you said that there was stenotic flow, and I'd just argue that I think this valve is opening up, you know, it's just crap.
It's just got no driving pressure.
It's just got no driving pressure to open it.
Yeah.
So I guess that'd be my first call. Second thing, let's talk about, I know you were just chatting away and you were talking about things, but when I'm just asking for the conclusion, honestly, just give the conclusion. So
You don't need us to write LV. You just want us.
I want to see this. This is what I'd put it down. So I'd put it down as a mildly dilated left ventricle with severe concentric hypertrophy. I reckon we got severe left ventricle systolic dysfunction. And I called it global hypokinesis. But if you wanted to call regional wall, if anything, I'd have thought it would have been the inferior. And so we go back to have a look at regional wall would not be pass fail. I think even if you got two experts, they're going to disagree. So the idea is that you've just got to call it severe dysfunction. Could you just tell me there was LV dysfunction? If you don't tell me it's severe, I think that'd be a fail for me. All right. So again, if you're going to call it, I mean, I hate moderate to severe or mild to moderate, but you can put that in the exam and I'm not going to fail for it, but it'll give me the shits, but that's okay. I might not be marking the question. I think I've got that wrong. That is not moderate left ventricle diastolic dysfunction. Excuse me. That is severe diastolic dysfunction. The E to the A is greater than 2. So sorry about that. That is severe left ventricle diastolic dysfunction. And if you're going with that, don't forget it always comes with diastolic dysfunction is always paired with left atrial pressure estimation. So Joe, you got that beautifully. You said severe diastolic dysfunction with raised left atrial pressure. Very, very nice. The next thing I love that you said is there's likely a chronic component to this. I think that's really important to put into the conclusion for this guy, because I don't think this is acute. There may be an acute component to it, but there's clearly some chronicity to it because you've got thickened walls and you've got severe diastolic dysfunction and you've got a big left atrium with raised left atrial pressure. I'd have taken normal RV size. You said a normal systolic function. That would have been fine. Mild tricuspid regurg, moderate pulmonary hypertension. Again, I think you said that was significantly raised, totally fine. And then don't forget the left apical mass on the contrast study that I did.
Yeah. Yeah.
So nicely done is the bottom line. The only things that I got looking through it again was talking about atelectasis. So I'll just click up to the top.
Yeah,
one.
I did actually write atelectasis on the sheet.
Nice.
I was trying to write things as I was going down.
And of course, I think if you'd had more time, you're good to go.
Yeah.
So I think you got everything. And if there's, so I think you got everything just partially sort of overcalled mitral stenosis. If you can't see it, don't add it in because there was no mean gradient. So severity was going to be hard. There's limited color Doppler. And again, I think the 2D appearance is not suggestive of that. But
I think I was
great job.
Yeah, I think I was just thinking about because he was a young chap, you see, and I was thinking, what's the etiology? That's all I could think of all the way through this was what's the etiology of all this. So
yeah, good call. Good call. Yeah, Ravi.
Sam, just your comment on the dilated LV with concentric hypertrophy. How did we come to that conclusion?
I mean, I think eyeballing it, you can see that we've got slightly thickened walls, or slightly, I think they're probably even almost moderate to severely, because they're almost up to 18 millimeters on both sides. I think just eyeballing it. And then with some dodgy M mode, agree, I think probably imaging would be a bit better if I was giving it to you. But here I've got, it looks like severe concentric hypertrophy there, particularly when you look at the LV mass.
Mass index. Yeah.
I don't think with the hypertrophy, I don't think we'd be necessarily going to jump up and down too much about whether you're talking about its mass. I think just saying there is hypertrophy.
I can't hear the audio very well.
Sorry, say that again. Sorry, did someone ask a question?
Yeah, your sound was a bit off then.
Yeah, your audio is not quite unstable, Sam. I don't know if everyone else is feeling the same.
I'm really sorry. The internet is very dodgy and I'm having to go off my phone. We've lost some of the internet at Nepean. So I'm really sorry. That's what it's like being in Western Sydney at the moment. If you can't hear me very well, please just put your hand up and I'll have another go. I was just saying for the hypertrophy, just saying there's hypertrophy is probably enough for the pass fail. I don't expect you to have a look at the mass and tell me, specifically whether we've got any kind of concentric hypertrophy or things like that. If you can make an estimate at mild, moderate, or severe hypertrophy, that'd be the cherry on the cake. It's just noticing the hypertrophy is important.
I'm sorry, I missed the first 5 minutes. So this is like full reporting for the Vivas or?
No, this is full reporting for the written.
For the written.
So in the written, the 10th question is not going to be a short answer question. It'll be a case discussion or a case that you look at. So that's why we're just going to go through this to give you an idea of what it looks like. Because I think my argument why I think this needs to be done is because this is what we do on a day-to-day basis.
Yes.
And I think it's really important to know how to write a conclusion. So that means that for me, you're going to get given a stem like this. You're going to have about 15 to 20 slides, and a slide may have multiple pictures on it, but you'll have about, I would say, give yourself 15 minutes to look through the case and then write down your findings in shorthand, just like Joe did. But then when I ask for a conclusion, so all you're being asked to do is write a conclusion. Your conclusion, I think, and again, this is just my method, but I don't think it's terrible, is to have a systematic pattern to it. So for me, the systematic pattern follows, and let's say it depends a little bit on what the stem is about. If it's clearly all about pulmonary hypertension and asking about right ventricle strain, then I start with the right ventricle. Otherwise, I start with the left ventricle, and I go left ventricle size, function, regional wall motion abnormality, diastolic dysfunction, left atrial pressure. And I think that's not an unreasonable way to start it, even if it's normal. So you might say normal LV size and function with normal diastolic dysfunction and normal left atrial pressure. If that's not relevant to the case, I still start with that because I think it's important. And then I move in to talk about the left-sided valves. And then I talk about the right-sided size and function. I talk about the right-sided valves. Then I talk about the pulmonary pressure estimation. I tend not to mention it if it's not significant. And then the final part is the key for me, which is about then integrating those, what you've just said, into the clinical findings. So just a sentence about, for example, on this one, it might be something along the lines of, there is a clear cardiogenic component to this gentleman's shortness of breath, which is likely chronic in origin. There may be an acute component to it. Urgent cardiology referral seems reasonable to investigate the cause of the LV dilation and dysfunction. Differential diagnosis may include ischemic/viral cardiomyopathies / other causes or something like that. Yeah. But just as long as there's something at the end that says that you're putting those echo findings into the clinical picture, and it doesn't have to be a super long conclusion. Ah, bugger, sorry. Yeah. So all those doing the written, I think this is, I just wanted to get a vibe of what it was going to look like. Yeah. I think it's so. It's not. So again, the written is cumulative. I sort of wanted to make this a separate station unto itself that you couldn't pass if you didn't get this one right. But we're going to have a few more cases in there, but I didn't quite get that through this year. But so it's cumulative. If you fail this, you don't fail the whole exam. Remember, the written is a cumulative bunch of marks. You've got to get over, I think it's 60%. So it's marked out of 150. So you got to get like over 93 or something, and it's cumulative. But this one's got 25 minutes.
Is this, Sam, is this the same weightage as rest of the 9 questions?
Yeah, the same weightage, yeah. So it's still going to be marked out of 15. I think we're still trying to work our way around this a little bit. So we're still trying to figure out what's what. And so you know, I think it may change in the future, but for you guys doing the written, and obviously I know some of you aren't, but for you guys doing the written, yeah, so it's cumulative scores on the written test. They take that mark, and that's either pass fail if it's above 60, and then 60%, and then it's pass fail for the Viva, and you've got to pass both to get the ticket. Happy days? All right, let's do another one. Who's next? Ravi, do you want to go next?
Yeah. Yep.
Love it. So it's always bad when I okay. These are just sort of full cases, so I'll just flick through. So I'll do it a bit more in a Viva style. So I'll probably look for five or so screens. So let me just flick through them as we go. Okay. Let me know when you are ready to move on. So I'll let you read the question first.
49-year-old female suffers of breath, chest pain, back pain, refugee, anxious, past medical history nil, borderline SATs, serial component negative, minor ECG changes, X-ray chest showing minor pulmonary edema.
Good to go.
So long axis view, mitral valve, a very thickened mitral valve with restricted opening, and possibly like heterogeneous ecogenic material at the tips of the mitral valves, which is not having any independent motion. Sorry, it's the frame rate is very low here. It's
oh, sorry, buddy.
there's no
I'll
frame
try and
rate.
get this internet better.
And the aortic valve appears normal. The left atrium appears dilated. The anteroseptal and inferolateral walls are moving well. The MV systolic function appears normal. And the right atrium might be slightly dilated. So the differentials for this, based on the patient's presentation, primarily could be infective endocarditis. However, I would like to confirm with different views.
Let me.
So there's a color Doppler across the mitral valve, which is showing the posteriorly directed mitral regurgitation. And it's a wall hugging check, so it's likely to be at least moderate mitral regurgitation.
Can you tell me more? Let me just try and find another view. Does the mitral valve look normal to you?
No, the mitral valve is abnormal.
Yeah, so I think we probably have a better question, a better prompt than that. Sorry, you know what I mean? Can you tell me more about the mitral valve?
Yeah, so the mitral valve is thickened. The leaflet tips the anterior mitral valve. Leaflet is there's a restricted opening, and at some point it looks like pockystic appearance. The posterior mitral leaflet is comparatively more thickened, and there's highly ecogenic ecodense material at the tip of the posterior mitral leaflet.
Is there one part of the leaflet that appears more thickened than another?
Yeah, the tips.
Well, are there any other
So-
diagnoses you can think of other than infective endocarditis that can give this appearance?
It could be non-infective endocarditis.
It's okay.
Or,
Blah, 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 blah.
or that there could be lipoma or some primary malignancy like fibroelastoma.
Okay, describe your findings on this one.
So this is a parasternal short axis view at the base. So at the mitral valve leaflets anterior and posterior. So the echogenic material is seen on the.
Sorry, keep going.
At the E3 and A3 segments, scallops of the mitral valve, and
Okay, we're going to move on to the apical four-chamber view, and this is continuous wave Doppler.
continuous wave, which shows mean gradient of 10.5. So that will be considering the 2D images that we have seen from now, it will be severe mitral stenosis.
Excellent. And what do you think the etiology might be of that?
So it could be the tips are affected. So this could be rheumatic affection of the mitral leaflets.
Beautiful. Beautiful. So what other views do you need to assess the severity of this mitral stenosis? You've got the mean grade in there, which made you think it was severe. What else do you need to measure the severity or to back up your severity assessment?
So we could also do pressure off time in the same view, or planimetry of the mitral leaflet in the parasternal short axis, which is not very reliable, especially if it's a damaged valve. That's not very reliable. And yeah.
That's right. Okay, nice one. Let's go through some of this stuff. So again, if I'm going to ask you about valve stuff, there'll be some prompts in there, and just be careful about going down the wrong route, right? Because this is rheumatic mitral valve, and just keep looking at the way that those valves move, right? Where you get that tiny little exit and it looks like that hockey ship appearance.
Yeah.
Okay, so it's just opening like that. If we're looking for, and I'm slightly off axis when I did this imaging, so you can see the papillary muscles coming in, which I think was what you were concerned that this might be infective endocarditis. I'm really sorry, guys. I'm just on call for the echo lab. Do you mind if I just quickly just take this? Excuse me. Yes, sorry. So I think we're looking at the papillary muscles. You see them going all the way down. They're definitely thickened. I think the posterior one, it might be a little bit more thickened than the anterior. But I think just try and remember this. We obviously don't see a lot of rheumatic mitral valve disease down in New South Wales or down in Southern Australia or Southern Western Australia. I'm guessing we got Drew might have picked this up straight away at the beginning because he probably sees more patients with rheumatic fever and rheumatic mitral valves than he sees normal. So he'd probably look at this and say, "Oh, it's totally normal." No, I'm joking. This is so just have a good look at what a rheumatic mitral valve looks like, and absolutely we've got to be able to know how to assess it. So it might be worth just having another read through about the mitral stenosis, is absolutely fair game. And
Yeah.
again, just stick with that idea. So what other views would you like to assess this valve? And then I just want you to think 2D features, color Doppler features, continuous wave Doppler features, pulse wave Doppler features. And then you're going to tell me, as you tell them, just a little brief caveat about why they might be inaccurate in a critically ill patient. So for this patient, you might say, what other views do I want? Well, the 2D features suggest mitral stenosis on the basis of the morphology of that. I'd like to see that in other views like the apical 4-chamber, subcostal, and short axis view. You can do the planimetry, like you said, which is a bit crap because I can't go through it's very difficult to find the actual annulus, and that's where we may consider transesophageal echo. Color Doppler, candle flame appearance, clear turbulent flow. Again, that is flow dependent, which can be a problem in the critically ill. Continuous wave Doppler, that is preload dependent. If someone is tachycardic, fluid overloaded, or they've got a bad cardiac output, that will under or overestimate the severity of the regurgitation based on mean gradients alone. Then I can look at pulsed wave Doppler, and I can do the continuity equation. And I can do the continuity equation trying to get the flux exactly at the tip of the mitral valve leaflet versus the LVOT, and use a continuity equation as long as there is no significant aortic regurgitation, as long as my measurements are correct, and all of those are tricky in the critically ill. Yeah?
Yeah.
Just work on, again, that spiel, and I guess for everyone doing the Vivas, the spiel's got to be perfect for MR, MS, TR, AS, AR. Just practice that 1 minute spiel for all of them. It comes up often.
In this case, the mixed mitral valve disease, because as Ravi said, is mitral
Nice,
to the,
very nice.
so things like it's going to confound all our flow measures.
Yep.
Moderate.
Yep.
And it's going to confound that continuity equation.
Absolutely.
Well. So all those things.
Absolutely.
Yeah.
And so I think it's just more about having that quick summary about how you measure valves, and then just a quick little bit about why it's tricky. And honestly, all we're saying is, if I look at my mean gradient, that is flow dependent. That's kind of all you have to say, unless the examiner is going to stress you a bit more. You know, as I said, it's like a minute per slide. That question in the Viva, we're expecting you to answer it in a minute. You know, they might rush you through it. So just try and get it short and sharp. All right, nice. And Ravi, any questions about that, buddy?
No.
All right, Prithvi, you next? Happy?
Yep. Yep.
All right. Let's choose something really hard.
No hard cases, just something.
Oh. No, that's a bit unfair. All right. Let me know when you're ready to move on.
Yep. So urgently called to ED, registrar request surgeon echo, history of mechanical MVR 10 years ago, and a recent UTI, upper respiratory tract infection, stopped taking warfarin whilst on antibiotic, thought they would interact, and 24 hours of shortness of breath.
Nice. What am I about to show you?
Probably a blocked mechanical mitral valve in the context of stopping anticoagulation.
Nice one. And Ravi, I'm sorry, I didn't do that for you on the last one as well. So the last one didn't have anything in there about her being septic. She was just short of breath. And I think she said she was tachypneic, but a refugee was in there. And I think if we're going to have things like that in there, you know, it's like if it's a farmer in the exam, you know, they've taken some form of paraquat overdose, or if it's a young pregnant woman, she's going to have help or preeclampsia or something. You know, it's in the stem. You know, they're trying to give you clues in there, so just make sure, you know, I wouldn't say refugee and they're going to be an IVDU, am I? That's just not right. If I say IVDU, then you know they've got infective endocarditis. things like that. So just use all the information available to you. The examiners, again, we're not trying to trick you. We just want to get you in a zone where you're not going to miss obvious stuff. So yeah, cool. All right. The pictures are a bit average. Let's see if I can give you something that's not average, maybe. Let's start with that. So what kind of valve are we looking at? I think I gave it away, didn't I? No, I said it was a valve replacement. What kind of valve are we looking at?
I mean, it's difficult to even visualize the mitral valve. There's a lot of calcification and possibly thrombus around the valve, but I would say probably a mechanical mitral valve because I've got the post-acoustic shadowing.
Yeah, absolutely. That can't be bioprosthetic because you've got that wonderful reverberation artifact coming down from those valves. Beautiful. So, and I know the pictures are a bit dodgy, so we would ask you just to please describe your findings, on, even though the pictures are a bit average, but can you just describe your findings?
The most striking feature is the mitral valve. The mechanical mitral valve seems to be heavily thrombosed or stenosed. And there is the left ventricular systolic function looks quite normal, and the right ventricular systolic function quite normal. Patient's obviously very tachycardic. There is a highly echogenic looking mitral valve, which could suggest either a thrombus or an acute stenosis of the valve. I can't particularly look at the architecture of the valve, but I could see it has got very restricted mobility and restricted opening. I'm unable to look at the left atrium properly because of the shadowing from the valve, but I would think that there would be a dilated left atrium because the valve looks pretty completely occluded. And the fact that the patient is so tachycardic at 138 suggests that there's hardly any blood flowing into the left ventricle, and the patient is compensating with a severe tachycardia.
You said that you thought the valve was stenotic, and that's hard to do because you said you can't look at the valve. What are you looking at to try and tell you whether that valve is opening normally or not?
At least on the 2D image, I'm looking for some sort of leaflet mobility, when here as hardly doesn't seem to be anything, but again, it's quite masked by the thrombus there. Okay, so that's color wave Doppler and continuous wave Doppler across the mitral valve, and I'm getting a mean gradient of 28, which suggests quite severe stenotic mitral valve. But the caveat is the patient is quite tachycardic.
Yeah, no, so I'm going to stop you on that one. I wouldn't know. It's what is it? It's quite severe. It's severe. Just say
severe. Severe.
Yeah, not quite severe, quite average, quite moderate, quite thickened, quite hypokinetic. We heard the other week. Yes. No, just call it. Say it.
Severe.
Nice.
And the caveat is the patient is quite tachycardic. So that could confirm. But in spite of that, looking at the 2D appearance and the context, I would say this is still severely occluded mitral valve.
Nice. So what are the confounders to that mean pressure gradient?
I think main thing is the first thing is tachycardia, the severe tachycardia. So that is going to overestimate it. Also, the measurement in this context of it's not a native mitral valve, it's a mechanical mitral valve. So I'm not sure if that the continuous wave is going to give me the right sort of measurement. So I can think of.
So what other views would you like to do to confirm the severity?
So I would probably try and look at the parasternal short axis to see if I can see the valve clearly and look at the calcification or the anatomy a bit more. But I guess with thrombosis and calcification, that is going to be quite tricky. With the
Again, just think 2D, color Doppler, continuous wave Doppler, pulse wave Doppler.
Yeah, so again,
Have another go. Let me just do it again. So just have another think about this. So we've got mitral stenosis again that we just talked about with Ravi there, okay? But we got a mechanical mitral valve with pretty shitty images. So I'll ask the question again. If I've just shown you this, what other views, you've called this severe stenosis or severe blockage of the mitral valve. What other views do you need to tell me the severity, to confirm your findings?
So first 2D appearance of a very stenotic mitral valve with continuous with color. I would probably see evidence of a lot of turbulence or aliasing at the mitral valve, and with continuous wave Doppler, I would be looking at a high mean gradient of more than 10, and a pressure half time which is quite prolonged, and with pulse wave Doppler, again I'll be looking at possibly low E velocities because of reduced flow across the mitral valve. But all this is going to be quite difficult in this patient, considering it's difficult images and there's a lot of artifact with the mechanical valve.
What's your management of this patient?
I think I'd probably need to look at the valve a little bit more in detail. These images are not enough. Possibly a transesophageal echo would be warranted here to look at the valve a little bit more, because it's difficult to comment with these images alone.
So and that tell me that when we were talking about what other views do you need?
Yeah.
Nice one. Okay, let's I think you guys need to go in, do a little bit more on stenosis, mitral stenosis, and particularly on prosthetic valves. All fair game in the exam, and absolutely I'd love to put these in there because people, if they're not, they don't do them a lot, but you need to know about them when you see them. So I think, what's that?
Can I say what I would say?
Yep, let's go for it. Let's hear what you got to say.
So I've seen the same images as you guys. So I guess.
So I've shown you that. And then the question is, what other views do you need to confirm the severity?
So I'd like to assess the valve in multiple transthoracic views, including on and off axis, in standard 4-2-5-3 chamber and a subcostal. I'd like to interrogate each view with color Doppler to look at flow profiles from what I can see. I'd like to put continuous wave through the 4, as we've got here. I also like to do that through the aortic valve in the 3 and 5 chamber. So I need to get a VTI over both valves for an assessment of severity. And then I'd like to see, I've got my peak. So I've got my mean velocity here already at 2.5, which is consistent with severe mitral stenosis in a prosthetic valve, metallic valve. And so whilst all of these measures that we take, such as gradients and peak velocities, are flow dependent and rate dependent, ultimately I need to do a transesophageal echo to better visualize why this valve is obstructed. So something like that, just off the cuff. And then I also like to see my right ventricle, because her degree of tricuspid regurgitation is another marker in assessment of mitral stenosis severity when the TR is sufficiently high.
Yeah, I think that was better. For you get the difference? Did you hear that okay?
Yeah.
I think it's just, it's that punchy language. It's the clear, you know, you're not having to think about what to say next. You've got a structure, you've got to move on, you know what to do. One of the big things also for me, just from a management point of view, is you compare, just like you do with aortic stenosis, you look at the dimensional severity index, do the same thing with the mitral valve, but I've got a cutoff of about 0.4 rather than 0.25 or something. All right. So here you can see I've got a VTI of 10 for the VTI, whereas we've got a VTI of 60 over here. So that's clearly super low. That's like whatever the it's like small 0.15 or something, isn't it? So that's like it's 15. It's super, whatever it is. It's super low. It's much less than 0.4. The caveat to that is, again, is you can't do it with aortic regurgitation or with significant mitral regurgitation. So the key part for me is the talking about multiple views. You got to say that straight up. You've got to say you're going to be going to a toe if you can. You got to be talking about multiple assessments with Doppler in every single goddamn angle you can, including off-axis imaging, because this is absolutely 100% life-threatening. And if you get this wrong, that's a major deal, because what's the management? It's you're calling a cardiothoracic surgeon, or if you're far away from, if you don't have cardiac surgery in your hospital, just like we don't here, you thrombolize this lady. And what happens to the thrombus? Well, it doesn't just magically disappear, it breaks off. And then you've got the risk of stroke, limb ischemia, knocking off a kidney, knocking off a limb, whatever. It's absolutely rip-roaring. And that's unfortunately exactly what happened with this poor lady. And she had a massive stroke and she died. So we didn't do a toe in this lady because she was so unwell. Oh, sorry, the other thing to pick up is the really underfilled left ventricle, because it can't get goddamn blood into it. And that's why the right ventricle, if anything, looks a little bit dilated. Where was the view?
It's all relative, right?
Yeah.
Bigger than
so the RV looks big, second to the left, and you can see the change in it.
I mentioned the left ventricle being quite underfilled because
so
of the
LV's underfilled. That septum's almost sucked over because the right ventricle changes in gradient because of the weird pressures. So this lady was just sick as a dog, and what can you do other than try and get her to surgery? The delay is going to be extensive. She's becoming hypotensive. Give her some thrombolysis and just tell her this is really, really bad. And that's why you take anticoagulation when you have mechanical aortic valve, or mechanical valve. Joe, your hands up. Hi.
Yeah, hi. The DSI value, what was that again? 0.2?
They talk about 0.45. Let me show you where I get all this from. So
is that different to when you work out the VTI mitral valve for prosthetic valves over the VTI?
It's different for, I use it particularly for prosthetic valves. Let me just show you the lecture that we haven't done this. It might be worth trying to read. I'm just going to pull it up. Just give me 1 second. I'm trying hard to do two things at once.
Have you seen the ASC guideline statements?
Which is where this is from. I'm just about to show you.
Yeah. Because it said 2.2, it says more than 2.5, but is that the VTI mitral valve?
No, that's not the VTI. That was the peak gradient, I think, is what it's talking about. But that is being shown. If I do that, you can see it. Okay, so this is all stolen from all these. This talk, which was done by Stephen Huang, a great talk. Hopefully we recorded it. Hopefully it's somewhere. It's all stolen from the ASC prosthetic valve assessment guidelines, as well as all the pictures from it. They all come from that. And they talk about how to assess it. And you'll know the way they start doing it in terms of 2D echocardiography and Doppler, both color, continuous wave, and pulse wave. I didn't make any of this stuff. I'm stealing it off other people, everything I say, of course. I think talking about the difficulties with all of them, 2D, you've got shadows. Sometimes it's hard to image patients, blah, 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 blah. Color flow can be tricky. You've got washing jets, you've got not. It's flow dependent. It's often eccentric jets. Regurgitation's hard because it's often got a shadow. Continuous wave Doppler is difficult because you're going through valves. And this is where you can start to do your dimensionless parameters. So the VTI of the prosthesis compared to the LVOT VTI. If you've got obstruction or stenosis, you have a low VTI, a low dimensionless severity index, dimensionless velocity index, whatever you want to call it. Pressure half time's a bit rubbish. And so that's where...
They do effective orifice area.
Yeah, this is where I steal it from. So if, I hope you can see that okay. So looking for prosthetic dysfunction, you look at a mean gradient. If it's greater than 6 or 15, and obviously that's not in a critically ill patient. For me, if you're tachycardic with a hyperdynamic circulation, 15, greater than 15 millimeters of mercury for the mean pressure gradient for a mitral valve. And I stole that from the exercise, you know, when they're doing exercise stress testing, echo exercise stress testing, they have 15 as the magic marker where they talk about functional mitral stenosis. And so if you've got a thickened mitral valve and someone gets short of breath with exercise, if you do a exercise stress test on them and their mean gradient goes above 15, they talk about functional mitral stenosis. And I was thinking about giving you a case. We got a great case. We couldn't wean from the ventilator because they had, you know, horribly thickened mitral valves. And that's fine when they're at rest and they open up normally. But when they're exercising, you got them on a ventilator and a little bit septic, the mean gradients went up to 20. And that means that they had functional mitral stenosis. I couldn't for the love of money persuade the cardiologist that that was a true thing, but it's why they were difficult to get off the ventilator, I'm sure of it. And that's why you look at this dimensionless severity index. I have 0.4, I have 0.45 written up there. I have 0.4 and 0.3 in my mind for the aortic valve and the mitral valve respectively. And then you can go and try and do, if you can, your estimated orifice area, which I've never really been able to do with a lot of confidence in the critically ill, I'll be honest, even with transesophageal echo, but you can do your best. And obviously lots of caveats, such as regurgitation of the aortic or the mitral valves. It's going to mess it up. All right, it's time. Any questions? Oh, sorry, there's a chat from someone. Sorry, someone's made a comment.
Oh no, that was just me from the first question. Yeah.
Thanks very, very much, guys. I'll see you next week. You're probably getting a bit bored of me. I'll see if someone else might be able to take it or talk about it. But if they can't, you might be stuck with me again. But we'll see how we go.
That's great. Thank you, Sam.
Take it easy, guys.
Thank you, Sam.
Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.